You're worried about it? Oh, give my info. What is it? So this is now. She wants to sleep so bad. We have time.
Oh, sad. Sorry. I saw you and I was like, why isn't he coming in? Can't get it. Oh, I think I saw his problem. I think I'll put that here. Cold.
You guys are feeding me.
I know.
Oops, sorry, so sorry.
I think the reason she's so cool is to switch it
And red is like
like 2 sets from each site, so 4 different ones? Or
No, just 2 sets and then 2 different sites.
So I would draw out all of the different, I draw all the different waveforms.
Okay. Lesson. This is the goal. Okay, guys, let's talk about it. List all the things that I want. Okay, so physician orders a patient in septic shock to receive a large IV fluid bolus. How would the nurse know if the treatment was successful for this treatment? Okay, so let's start from down here. Urine output of 20, is that adequate? No. Okay, so that's definitely not the answer. Patient is warm, patient's skin is warm and flushed. Is that gonna tell me that my fluid is working? No. Okay, it's just gonna tell them that the blankets that you put on is working. Okay, patient CVP is 2.
No, we wanted like an 8.
We want it higher. Yes, absolutely. We want to show that we gave fluid. So it should, yes, it is normal, but we want it on the high side of normal, okay? At least greater than 6 to 8, okay? So we know that if we gave a fluid bolus, how do we know that it's working, right? Our blood pressure went from 78 to 48 to 110/82, okay? So you're looking at things. And if you were to do the calculation, would my map be better from this map? Right? It absolutely would, okay? So we know that the map has gone up because we gave them fluid bolus, okay? Again, make sure you're understanding how to evaluate if your interventions worked, okay? So, neurogenic shock. We're kind of changing gears a little bit, okay? How will the patient present, and then what kinds of causes, okay? What kinds of causes? This is important because you need to know how you can differentiate between the different shocks, okay? You need to understand how to differentiate. This person in neurogenic shock will present differently than other people in the shock, okay? You guys are making me hungry. I feel like it smells like Mexican food in here now.
Right here.
Okay, so neurogenic shock, right? So let's talk about the causes really quick. We have some of them. I think it's funny. Spinal anesthesia. Okay, so the most common injuries that you will find that cause neurogenic shock is cervical and thoracic injuries, okay, to the spine. That is what's going to send your patient into neurogenic shock, okay? Cervical and thoracic is most common. Yes, spinal anesthesia can cause it. Yes, you could see Guillain-Barré could cause it, right? But the most common that I would like you to be aware of is cervical or thoracic spinal injuries, okay? Can send someone into neurogenic shock. Now, oh, look at that. They just typed that out. Perfect. Loss of sympathetic tone. Yes. So with neurogenic shock, right, the patient is going to have a significant loss of all sympathetic tone, okay? Massive vasodilation. Why I'm telling you that is that's going to be important as to how the patient's going to present, okay? So oftentimes, this is the difference, okay? Please make a note of that, is they are going to be bradycardic. This is the only shock that they're going to present with bradycardia, okay? So they're going to be bradycardic, hypotensive, and then because they have that massive vasodilatation, right, where they have like massive venous pooling, their skin is going to be oftentimes warm, flushed, okay? So you need to make sure that you are monitoring their temperature, okay? So I'm gonna go back here. You guys back here, you gotta hang out with me for a second. What are we on, 4? Yeah, okay, so 4. Okay, so how I want you to remember it, right? This is someone's head, and this is their neck, that's broken. I'm gonna say broken. Oh, I should make the head kind of fall off, yes. So, here's their head. It's kind of falling off, okay, so it's broken. So, cervical and thoracic. You guys are gonna remember this now, I tell you. Injuries, okay? That's usually the cause, okay? And that's gonna be really important when we talk about cervical because that's also gonna be something that you need to be thinking about and guide some of your treatment, okay? So the cardinal things that we deal with are Brady, right? They're bradycardic. They're still hypotensive, okay? And then we're gonna say thermodysregulation, warm skin, okay? So now, especially when we talk about this cervical spinal injuries, okay? I think I'm jumping ahead of myself. I will. Let's go to the next slide and then we'll talk. So sorry. So sorry. Questions about how they're going to present? No? Okay. Oh, I thought we talked about it. Okay, we'll continue. Okay, so with cervical spinal injuries, okay? Now, has anybody ever heard of the phrase C5 stay alive? Okay, so anything above C5, any issue, so 1, 2, or 3, or 4 that are broken, that you've hindered, okay? So I'm gonna put C5 stay alive. Anything below that, C1 through C4, you need to be thinking airway, okay? So if you have someone that dove into a pool, for example, hit their head on the bottom, and they have a cervical spinal injury at C2, for example, okay? You need to be thinking that their airway is going to be compromised, okay? Their airway is going to be compromised, and they are probably going to need some sort of definitive airway.
C1
Okay.
C4 they need to.
Correct. Anything above C5. C5, stay alive. So anything below that, hopefully you won't have any sort of airway issues, but above that, or below it, I know, it's just because I'm thinking of your neck and like above below, right? So anything below C5, C1 through 4, you need to be thinking airway, okay? So again, if you have someone that presents and they have a C2 through C3 injury, they're in neurogenic shock, you are worried about all of these things, absolutely, okay? But you also need to be thinking airway now, okay? You need to be thinking that they probably might buy themselves an ET tube, okay? Because they're gonna need a definitive airway. They're going to lose that strength in their diaphragm, okay? Sorry, I'm very close to you. Okay, now bradycardia. How am I gonna treat this? What drug do you anticipate possibly giving? Atropine, I love it. Because remember, with our broken neck, we've lost SNS tone. Okay, we've lost it all. Massive vasodilation is happening. BP, what do I want to do for this? Okay, sure, you could do dopamine. Okay. Phenylephrine, yep, you told her. I don't think I'm spelling that right, but that's all right. Phenylephrine, and then what should we do prior to starting these vasopressors? Maybe some fluids? So fill the tank, right? Okay, and then thermodysregulation, essentially you want to be monitoring their temperature. Okay, monitoring their temperature. Okay, so again, when you have someone that has cervical spinal injuries, okay, anything below, right, we're just gonna say C1 through C4, we need to be thinking airway, okay? So if your patient presents, right, and they are starting to desat, they come in, you're noticing they're bradycardic, they're hypotensive, and you're like, oh, I remember this. This is neurogenic shock. I know what to do, okay? And you start to see them desat, okay? And they're satting, let's say, in the 80s. What do you anticipate you needing to do? Okay, so you want to put them some oxygen, right? In the meantime, you know that you can't leave them satting 80s, right? You can't just be like, oh, it's fine. But you can anticipate while putting them, let's say, on a non-rebreather, that their respirations of 5 is not adequate. We're going to intubate. Yes, exactly. Okay, so we know that you can't, even though you know that we're gonna intubate, you can't just leave them satting 80s. You're going to put them on some sort of oxygen in the anticipation of having a definitive airway. Okay, does that make sense? Okay, let's do this question. So when you guys are studying, this is how it should look. You should be giving these kinds of concept maps because you need to understand how to differentiate between the different shocks and then what you can anticipate the treatment to be, okay? So in this, how best to study, honestly, concept maps are gonna be keying for you, okay? Sure, if you want to do lists, that's fine, or charts or whatever, but again, you need to understand the differences of the different shocks to be able to figure out, well, which one am I talking about, and then what can I anticipate doing about it, okay? Okay, so a patient with neurogenic shock is experiencing a heart rate of 30. What medication does the nurse anticipate will be ordered by the physician's stat? What do you guys think? Atropine, yes, thank goodness, love it. Is that a mosquito? These mosquitoes are very bad, you guys, right now. I swear I just saw something flying around. I got a bug bite, I'm gonna be very upset. I don't know why it's in here. There's no windows in here. They love you too? Same, they're the worst. And I have no self-control when it comes to itching. Zero. This is why I have Benadryl cream in every like pocket that I can possibly put it.
Oh, does it help?
Yes? You've never tried that?
No.
Oh,
I
Fred.
tried hydrocortisone.
No, okay, hydrocortisone, yes, sure, but Benadryl cream, it works.
Okay.
Excellent, highly recommend. You're welcome.
There's a mosquito right there. There was a big mosquito. You got Alex.
Did you catch it? You did? You're the best, thank you. You saved us all. It's a fly?
I definitely saw a fly. I found on the mosquito.
I swear it looked like a mosquito. I hate mosquitoes.
They love me.
See, that's what we were just talking about. I'm also, I can go outside and then all of a sudden I'll have 10. And I feel like right now, I don't understand, but they're very bad. Very bad. Really?
I heard it has a lot to do with your blood type.
Right next to each other.
That's crazy. What'd you say? It has what?
It has a lot to do with your blood type.
I've heard that too.
Yeah.
Clearly I have a bad one. Because I get like,
A positive, and they said that they love those.
what is it?
A positive.
Me too. Okay. Dang it. I hate that. I'm the person that, I mean, I don't care. I'll put D. All bug spray on me. I'd rather have like some sort of situation besides bug bites. I'm the worst. All right, let's talk about this. I know I can talk about all day the bug bites. Okay, so you're developing a nursing plan of care for a patient with neurogenic shock. As a nurse, you know that due to venous blood pooling from vasodilatation, a deep vein thrombosis can occur in this type of shock. A patient goal is that the patient will be free from the development of DVTs, blah, blah, blah. Okay, so select all the nursing interventions below that can help have the patient meet this goal. Okay, should we perform range of motion exercises daily? Absolutely. We should definitely be doing that because again, remember, someone that's in neurogenic shock, most common cause is cervical and thoracic injury. So they are not going to be getting out of bed, right? They're going to be laying in bed. So we need to help prevent them from getting DVTs, okay? Place a pillow underneath the patient's knees as needed. How would that help us? It wouldn't help us at all, right? That's not going to help prevent DVTs. Administer anticoagulants as scheduled per physician's orders. We can anticipate that they probably will be on sub-Q heparin, Q8, 5,000 units, right? And then last but not least, apply compression stockings daily, right? Those SCDs are going to be very important. Again, these people are probably going to be the ones that are not going to be moving, okay? So we need to make sure that we're preventing DVTs. Some of the nursing interventions you can anticipate. Okay. Changing gears a little bit. The last shock. Yay, we've made it, okay? Show patient presentation. Your patient is admitted for urosepsis. You are hanging ciprofloxacin. After a few minutes of the antibiotic infusing, the patient's blood pressure is 80/52, heart rate of 120, oxygen saturation drops to 87%. Audible wheezing is noted along with facial redness and swelling, okay? So if you could underline something, I would underline audible wheezing, okay? Audible wheezing and then facial redness and swelling. So, last but not least, what are we looking at? What's happening, okay? And then this is the type of question you will see. What do you do first? What do you do first? And then what medications do you anticipate seeing? Or excuse me, giving. Seeing. Well, I guess you'll see it, but you should also give it. this right here?
Yes.
So I can write right here? Thank you for saying yes. We'll just put search on. Oops, wrong side.
I know, literally, you know?
So good at drawing. Okay, so what is happening? What do we think is going on? Yes, the last but not least. If anything, you just did process of elimination. So we have anaphylactic shock. Anaphylactic shock comes on fast, you guys. Super, super sudden. Okay? And the first action, you see your patient doing this, you're hearing the wheezing, you need to be calling someone and then also turning off the antibiotic. Because we can think that what was going on in this situation is that we just started hanging ciprofloxacin, okay? So even if you're not sure, that's the precipitating event. So you turn off the antibiotic, you turn it off, okay? And then you anticipate that you are going to give lots of fluid, okay? You're going to give lots of fluid. So here's my little diagram, okay? These are the common things that cause anaphylaxis. Peanuts, you know, that's how it is, right? Bees, okay? And so you want fluid, right? That's gonna help take care of that hypotension. Now, the one thing I want you to be thinking about in terms of symptoms is wheezing. Okay, wheezing is one of the cardinal signs that has to do with anaphylaxis. Okay, what's happening? Why is someone wheezing? Constriction. So let's see, equals bronchoconstriction. So essentially, your airway is closing. Okay, so wheezing is bronchoconstriction. Airway is closing, okay? So we want to give fluid. What can I do to help with my wheezing? Okay, you could give albuterol. What's kind of a twofer that you can give? Epi. Epi is going to help vasoconstrict plus bronchodilate. It's a twofer. Okay, but yes, you can absolutely do albuterol. That's going to help. Albuterol. That's going to help bronchodilate. Sure, I love it. Okay. What's some other treatment that you would anticipate? So when we have anaphylaxis, you have this crazy release of these what is it called? Mediators. What is it? Maybe. I'm not sure if they're called. I can't remember what it's called. My brain is not working as quickly as it was. Anyways, you have all this histamine release, right? So what would be something that would be an antihistamine?
Benadryl.
Benadryl, exactly, okay? Benadryl, did I do that? Yeah. And then, last but not least, IV steroids. So fluid, lots of fluid. This is gonna help your hypotension. Epi is gonna help vasoconstrict. So that's gonna work in hand with filling your tank, right? Because you're hypotensive. And then the albuterol plus epi is gonna help bronchodilate. Because you're pulmonary wheezing. There's one symptom that you can associate with anaphylaxis is wheezing. No other shock is gonna have pulmonary wheezing. okay? Why? Because you have bronchoconstriction happening. Your airway's closing. Swelling is happening, okay? So it's super fast. Yes, obviously you want to give O2 100% because as you saw, we got some desatting happening. So O2, epi, Benadryl, right? What else? Aggressive fluid treatment, IV steroids, and then albuterol to help with those bronchodilation, okay? Again, your first action though is that getting rid of whatever's causing it, okay? So if someone's eating peanuts next to you and you have an anaphylactic reaction to peanuts, they need to leave with their peanuts, okay? They need to get out. You got stung by a bee, well it already happened, but you best be seeking this kind of treatment, okay? Because it's gonna happen fast and it will lead to death if not taken care of, okay? Okay. It's what it is, it's not immunoglobulins, I don't think it's IV,
IVIG.
yes, IVIG mediators is what gets released.
No, it is immunoglobulin.
Is that the other name for it? Immunoglobulins?
Specific antigens
Okay. Yes.
For this one, should we leave a epi?
Yeah, you can. You can. Yeah, you can.
And Nora?
Yeah, all of them work. Yes. Epi is going to be again like your big daddy. So I don't think someone would necessarily go straight to epi, but you can absolutely do epi 100%. For that one, you can.
And that's exactly what we prefer.
The take-home message is you don't want to start a vasodilator. Any of the vasoconstrictors would work. Oftentimes it's going to be physician preference as to what they like. Like I had a physician when I worked in Flag who loved phenylephrine. Loved it. Everyone was on it, right? I have a physician now that I work with who hates phenylephrine. He'll order anything but that. So again, it's very physician directed. Okay, as long as you understand it's a vasopressor, not a vasodilator, okay? All right, let's do this question. Okay, patient is in anaphylactic shock. The patient has severe allergy to peanuts and mistakenly consumed an egg roll containing peanut ingredients during his lunch break. That's a bummer. The patient is given epi intramuscularly. As the nurse, you know this medication will have what effect on the body? Okay, does it prevent a recurrent attack? Absolutely not. It does not. Once someone's has an anaphylactic reaction, they will always have an anaphylactic reaction, okay? What about it will cause vasoconstriction and decrease the blood pressure? Does that make sense? Absolutely not, okay? So be careful, right? You guys are nervous on your test. You want to get a good grade. You must read the question and the answers because I can bet that oftentimes people will be like, oh yeah, vasoconstrict, I know. But then they don't read the rest of the answer, okay? So I always tell people, take a breath, like literally take a breath, okay? Like inhale and exhale, okay? And then read the question again and then all of the answers, okay? Thoroughly. Take your time, okay? So this is not the answer, even though you desperately want it to be the answer in some, okay? And then this one, it will help dilate the airways. Yes, it's a twofer. It will vasoconstrict and bronchodilate, okay? That's why we love epi so much. And then it will help block the effects of the histamine in the body. Does it? What kind of drug does? Benadryl. Exactly. Perfect. Love it. Benadryl. Benadryl cream, like I said, my favorite thing in the world. Usually that's one of the stocking stuffers I get for Christmas. I know it's crazy, but do I love it? You better believe it. I know, it's crazy.
People give you Benadryl?
Yeah, my boyfriend has, yep. Because I go through it. Because the mosquitoes, you guys, the mosquitoes. I hate mosquitoes. I hate itching.
I feel that one.
Do we need to know the doses of the medications?
What?
Doses? How much to give?
Doses? No. Why do you think I don't need to give you the doses? Because it's going to show up on your MAR. It's going to show up on your MAR. Like in the hospital is what I mean.
0.5.
Does it?
I've heard B, D, E, and G. I don't know what the
Oh, wait.
For what?
All right, 30 more seconds and we'll talk about this, you guys. All right, you're providing education to a patient who has a severe peanut allergy on how to recognize the signs and symptoms of anaphylactic shock. Select all the signs and symptoms associated with anaphylactic shock. Okay, so do we think that hyperglycemia is a sign or symptom? Negative, ghostwriter, it is not. Okay, high blood sugar has nothing to do with anaphylactic shock. Feeling dizzy, yes, absolutely. Oftentimes it's gonna be one of the first signs. They're gonna be like, I feel off, what's going on? And then things happen very quickly. It's very sudden. Hypertension, are they gonna be hypertensive? No, they're going to be hypotensive, low blood pressure. Are they gonna have dyspnea? You better believe it. They're going to have difficulty breathing. Are they gonna be itchy? My worst fear, you guys. Yes, they're going to be itchy. They'll probably have hives, swelling, it's the worst. Vomiting and nausea, absolutely, okay? Are they gonna have a fever? No. Fever is indicative of infection usually, okay? And then slow heart rate? No. What is the only shock that will have slow heart rate? Neurogenic, okay? These people are going to be tachycardic, okay? All right, so we talked about cardiogenic shock. That's the pump doesn't work, okay? We're gonna have pulmonary edema with that. There could be coronary or non-coronary, okay? We talked about hypovolemic shock. Your tank is empty for whatever reason. Bleeding, dehydration, GI losses, you have to fill the tank, okay? 2 large bore IVs are going to be very important in that situation, okay? We talked about sepsis, the progression of sepsis, right? Sepsis is SIRS plus infection. You can have bacterial, viral, fungal, okay? Then severe sepsis is sepsis plus organ dysfunction. Lots of choices that you can have organ dysfunction. And then finally, last but not least, septic shock is that organ dysfunction with hypotension despite you filling the tank. So you anticipate starting some sort of vasopressor because again, we want an adequate MAP. Adequate MAP means end organ perfusion, tissue perfusion, right? And then treatment, time is life, okay? We need to do those things in less than 3 hours, okay? Then we go to neurogenic shock. This is the only shock that is bradycardic. Only shock that you'll see bradycardic. You anticipate that you will have to give atropine, okay? You will have hypotension and thermal dysregulation. Depending on where the cervical injury is, you may need to be worried about airway. Yes, you should put your person on oxygen while they're desatting, but you anticipate that respiration of 4 and 5 is not going to be adequate, and you're going to have get them intubated, help with that, okay? And then last but not least, we have anaphylactic. The only shock you will see wheezing. The wheezing is indicative of bronchoconstriction, your airway closing, okay? First, you get rid of the offensive causing agent, okay? You take the peanut butter away, you stop the antibiotic, okay? And then you anticipate massive fluid resuscitation, epi, that's gonna vasoconstrict and bronchodilate, possibly albuterol, Benadryl, and then IV steroids, okay? So you need to understand the symptomology. How can you differentiate between all of these shocks, okay? All of these shocks, right, the umbrella is that they all have a cellular disease. That's what's going on, okay? We have a lack of tissue perfusion at the cellular level, and we go into anaerobic metabolism, okay? We will see a rise of lactic acid in all of them. Yes, that is definitely the key cornerstone of septic shock treatment, but if you draw a lactic in any of these, you will see that it's going to be elevated, okay? We know that on all of these, we want to be providing enteral feeds, okay? At least within the first 48 hours, because we don't want that translocation of bacteria to happen. We want to maintain intestinal integrity, okay? Questions about this? No? Yes?
So I understand like the pathophys of all of them.
Sure.
Septic, like sepsis, like why are they anaerobic?
Why does it happen?
Why are they hypoxic? What about the infection is causing?
Yeah,
lack
totally.
of oxygen? Like
Totally.
I get the rest, they make sense, but that one.
But that one's hard? Yeah. So essentially what's going on with this infection, right, is that whatever, is it bacterial, viral, or fungal, we have bad toxins that are released, okay? It's endotoxins, okay? And then what happens is that at the cellular level, it causes cellular permeability issues, okay? And so those endotoxins are released and kind of wreaks havoc, and where your vascular tone should keep the fluid in, okay, much like your intestines when we talked about the integrity, you lose that in sepsis, okay? And so what happens is that you have this cellular permeability happens, and your tissues become flooded. And so where you should have the fluid, it's not. And that's why your tank is empty with this. So it's kind of twofold, right? So that's why, this is why your treatment happens, is you have to fill the tank, that's where your fluid comes in. You have to figure out where your blood, what organism you're up against, and then how to treat it is your infection, or is your antibiotic. Because what is the cause of it is the infection. Does that make sense?
I get like the general
Okay,
aspect of it.
so you
I
want
think the more like what you were talking about,
the endotoxin?
the endotoxins and the cellular stuff.
Yeah. So, and again, right, like I'm kind of just grazing the top
Yeah.
of it, but I think that if that's something that you need, that's something that I need, right? But I also know that for me to get to the nitty and gritty of like hypercoagulability and all that stuff, I know that people's heads are gonna spin and catch on fire, okay? But I encourage you, if that's something that you need, which I get because I'm the same way, then spend some time in the book and spend some time understanding that pathophysiology, okay? Because I just did a very down and dirty, like Reader's Digest version, okay? But I think that if that's something you need, then absolutely spend some time with that. Okay, does that make sense?
Yeah.
Okay.
Is this what we focus on, or do we go down and dirty to look?
No, I mean, I think that there's always merit to looking at the textbook, right? There's always merit. Like Alicia said, she needs that to understand that, and I support that. But I know that for many, I would love to get that deep, but I also know that we need to talk about respiratory for the rest of the class, right? I know that. And I know that if I go down deep and dirty, your people's heads will catch on fire. And I know that, okay? And so would I love to spend all the time talking about pathophys? You better believe it. Do I think it's important to understand it? Because it will help. It all ties together, right? It all ties together because if you understand the pathophys, you can understand how the patient's gonna present. If you understand what's happening, you can anticipate, well, how am I gonna treat this, right? But again, on the test, I'm not gonna ask you what endotoxins are released. I'm not gonna ask you about, the cellular permeability. We don't have time for that, okay? And again, I want you to understand if you encounter a patient like that, at the bedside, I need you to understand how to treat it, what nursing interventions you can anticipate, okay? Does that make sense? Yeah.
It's just stretching.
You're just stretching, okay, got it, stretch it out, okay. I love it. Okay, do you guys need a break or can we start respiratory?
Let's start it.
Okay, whoa, I mean that seems pretty affirmative right there. I'm down for
I
that.
don't think she speaks for us.
It's only half hour. I know that you guys are tired. I know that, but I just want to start it, okay? I just want to start it. I anticipate that we're not going to get very far, and I recognize that, okay? If you guys want to take a 5-minute break, that's totally fine. Go take a 5-minute break, go to the bathroom, and come back at, let's see, 2 minutes plus 3, 1:03. I know, so specific, but that way we can start. But go to the bathroom while I get this up and going. The mosquitoes there, the mosquitoes right, so you did not kill it.
Maybe there was more than one.
Yeah, I was gonna say.
Mosquitoes are back? Brittany, it's why you do that. Oh, guys, why are there mosquitoes in
I,
here?
I still love it.
I have a question. Yes.
When it comes to the shocks, septic shocks, like DIC, DKA, we have to go deep into those?
No.
Look into those.
All I need you to know, or talking about DK and DI, is that it's a loss of fluid. It's a loss of fluid.
And DIC is the last of when they get like the hemorrhage nonstop.
That's, DIC is something you'll see in septic shock.
Okay.
But again, I'm probably, yeah, just know that that's a possibility. You may see that, or in mods, for example, but not necessarily hypovolemic shock. Okay? Okay, thank you. Absolutely. Can I erase this or no?
I will stop speaking for everybody.
Okay, I'll wait until everybody comes back, because I don't want someone to be like, I needed that, and then it not be there.
Emergency technician.
Whoops.
A browser error versus immediate interviews. It is a browser error. Immediate interviews on next Thursday for browser. Same day job offers. We have the fair. Yeah, but it ends up to. You're right. You're right. Because this ends at 3. By the time
Sent
we-
today, email this morning, or something. And then she said that we will know.
What? Oh, no, it
She said
doesn't
we'll be
say that
assigned
I've been
this.
there, so I don't know.
I think it takes like 6 weeks.
I said, I also don't think they're not gonna send
Also, we're just doing different questions.
Right, but I don't know if they'll send us anything until we schedule it.
I had to call customer support, but they extended my, or whatever. They called me this morning. Cause I called them yesterday. I called them yesterday and talked to the customer support person, and they're like,
But it was ready.
yeah, you're just gonna have to buy them all over again. I don't have my $1,000 to drop again.
I'm like, the person literally told me in orientation in the call, this is how they put it on.
They should tell me that,
My mind, I don't think it has a.
they should tell me that, I'm like, I'm a nursing student, do you think I have that kind of money?
And then they just start coming
Yeah.
And then you said where everyone.
Why don't I have it for lunch?
But I didn't see that question. I don't even remember. Maybe there was two hours and that. I should let him know.
But I.
And then priorities were in 80.
You need internet access for the test.
Wasn't it turned on the AED?
Because those tests aren't available.
So you have that. Yeah, it'll be hard in a week or so.
Maybe until it unconscious you.
Yeah, so either you.
Alright guys, we got this, okay? We're just gonna tip, do the toe and the pull up fun for respiratory, okay? Okay. So we are gonna talk about the story of Mr. Pneumonia, also known as pneumonia, okay? It is an unraveling respiratory dilemma. Poor Mr. Pneumonia, he came into the hospital and he's pretty sad with his life, okay? Here's some objectives. You do not need to know about lung cancer. Yay for you. Do you need to know about everything else? Yep. So you don't need to know about lung cancer, okay? Okay, so Mr. Pneumonia is a 64-year-old male with a past medical history of type 2 diabetes, hypertension, ETOH abuse, see, I even need to go home, and a smoker, 2-pack a day. He is admitted to the hospital for a diagnosis of hospital-acquired pneumonia. Okay, he's admitted to a telemetry unit on 5 liters nasal cannula. Okay. As the night progresses, Mr. Pneumonia is increasingly restless. Okay, tachycardic, hypertensive, and tachypnic. He is using his accessory muscles now, and he's confused. He keeps trying to get out of bed to go to the grocery store. Why not?